Well, thanks for asking me to talk. Like Mike, I want to start by saying how nice it is to be giving travel medicine talks again after such a, what seems like such a long lapse where no one was thinking about travel at all. So I've been asked to talk about food and waterborne illness, Sorry, I'm going to talk about hepatitis A, typhoid and cholera vaccines. I'm not going to talk about rotavirus, which is part of the routine immunisation schedule in many countries, but is not specifically considered a travel vaccine. And I'm also not going to talk about polio, which Mike just talked about. And then I'm going to talk a little bit about travellers' diarrhoea. Mike already showed this slide, but I just wanted to put it in as well to highlight where the diseases that are spread by food and water fit on the stephanogram, and you can see that typhoid in South Asia is the highest among them, followed by hepatitis A and then typhoid in other places, and cholera doesn't appear on this slide, but it does down the bottom at less than 1 case per 10 million, so very rare. But we'll talk about each of these in a little bit more detail. So firstly, hepatitis A. You can see the CDC map there. I mean, most diseases that we show in travel medicine have very similar dark areas, particularly in Africa and the Indian subcontinent, where the risks of water and foodborne diseases are greatest because of poorer sanitation conditions, but also South and Central America. Most of you would know that hepatitis A is also spread person to person in addition to by contaminated water and food. So the people who are at highest risks are travellers going to the areas shown, as well as men who have sex with men, and also some occupational workers, particularly those who work in childcare or as sewerage workers. Overall, the incidence of hepatitis A globally is reducing as sanitary conditions globally are generally improving, and the most current incidence estimate that we have for acquisition of hepatitis A amongst travellers is about 1 in 10,000 per month. And so it's still an important vaccine preventable disease amongst travellers. I'm not going to go through the characteristics or clinical signs or symptoms of hepatitis A in any great detail, but suffice to say that hepatitis A virus has prolonged environmental survival, which is why travellers to areas where sanitation is not so good are at risk, and the virus can be shed in the faeces for many weeks after infection. The only thing I want to say about the clinical infection is that it can range from being an asymptomatic infection, which is often the case, particularly in young kids under 5 or 6 years of age, to all the way through to a severe disease that can have can be associated with fulminant hepatitis, liver failure, and potentially death. And that is the chances of a more severe disease increase with increasing age, with the overall case fatality being about 0.3%, but it jumping up to about 1.8% in people over the age of 50. And as I'm sure most of you know, chronic infection with hepatitis A, unlike hepatitis B and C, does not occur, and lifelong immunity is acquired after infection. Now, this is a busy slide, and I'm not going to go through it in any detail, except to say that there's a number of different companies that make hepatitis A vaccine, which are all largely interchangeable. We generally say that if you started with one brand, it's probably best to finish with the same brand, but they really are quite interchangeable. And then there's also combination vaccines of hepatitis A, either with hepatitis B or with typhoid vaccine. And for some of the brands, there's both pediatric and adult formulations. We generally recommend hepatitis A vaccine for people over the age of 1 year who are travelling to moderate to highly endemic countries. The vaccine itself is highly immunogenic in healthy children and adults. With a single vaccine shot giving protective antibodies for at least a year. And the usual recommended second dose is at 6 to 12 months after the first dose to increase the duration of protection. So if you see a traveller imminently before they're about to go on a trip, the first dose will protect them for that trip, and then they should have the second dose 6 to 12 months later. If that second dose is delayed, if people don't come back for some years, perhaps because they're not travelling again and they only think to come back for that second dose, just prior to their next trip, it actually doesn't matter if there's still good immunogenicity if you give the second dose later, and you don't need to restart the course. Nor do we think that any boosters are required once someone has had 2 doses. It's sometimes an issue, who should you who might already be immune, or it can be an issue to think about who should I vaccinate versus who may have already been exposed as perhaps as a child and therefore be immune. And the people for whom, if you're living in a non-endemic setting like Australia or New Zealand, you might decide to first test for hepatitis A antibodies in case they don't need vaccination, are shown here. But there's also no harm in just going on with vaccinating. I just want to mention that hepatitis A vaccine, or there's some evidence that hepatitis A vaccine is less efficacious, or the antibody levels that are produced are lower in people who are immunocompromised, and there's potentially also lower durability of the response, although there's less data on the durability issue. So for people who are significantly immunocompromised, you may need to give them 2 doses of vaccine prior to travel, and that can be either a double dose or 2 doses 1 month apart, but then another dose at 6 to 12 months for ongoing boosters is still required. Moving on to typhoid vaccine and Salmonella Typhi. Just to clarify that Salmonella Typhi causes typhoid fever, and enteric fever is the group name given to typhoid fever and paratyphoid fever. Both typhoid and paratyphoid are transmitted by contaminated food and water and by person to person. The travellers who are at most risk are VFRs, particularly those going to South Asia, but also other travellers who are potentially going to be less cautious with their food and water hygiene, such as backpackers, and also those who are going on longer trips, essentially because the longer you're away, the more chance it is that at some point there'll be a breach in your food hygiene. I've put this slide in to show where typhoid and paratyphoid are most common. You can see the darkest area being the Indian subcontinent. But I also want to point out that the typhoid vaccine protects against Salmonella Typhi, not against Salmonella paratyphi. And Salmonella Typhi causes about 3/4 of enteric fever. So even if you give someone the typhoid vaccine, people can still get paratyphoid, and even for typhoid, the typhoid vaccine is only about 70% efficacious. There's a number of different typhoid vaccines, an oral live attenuated vaccine, where we usually give either 3 or 4 capsules if you give the 4 capsules, the duration of protection is thought to be about 5 years. If you give 3 capsules, the duration of protection is about 3 years. This can only be given to children over the age of 6. There's also polysaccharide vaccines, 2 interchangeable polysaccharide vaccines. And then there's some newer conjugate vaccines which are not yet available for travellers, but are now being used in childhood vaccination programs in some endemic countries. And there's the combination vaccine that I already mentioned before of typhoid plus hepatitis A, and the one which is Vivaxin. And the one practical point I want to make about Vivaxin is that the components in Vivaxin are the Typhi VI vaccine as well as hepatitis A vaccine. And although Vivaxin itself is only licensed for people over the age of 16, in fact, you get good immunogenicity, and there's now a lot of data to show good safety down to the age of 2 years. So who do we recommend typhoid vaccine for? We recommend it for those over the age of 2 who are going to endemic regions where food hygiene may be suboptimal, particularly VFRs, and particularly those going to the highest risk area of Indian subcontinent, partly because Indian subcontinent is does have the highest risk of enteric fever, but also because a lot of the enteric fever acquired in the Indian subcontinent is antibiotic resistant. So protecting our travellers becomes particularly important. The last travel vaccine I want to very briefly talk about is cholera. It's not used much in travellers. Mike alluded to on his slide, or flashed up very quickly, that we essentially tend to only use the cholera vaccine for people who are going to work as aid workers in refugee camps. And that's because cholera amongst travellers, as we showed in the stephanogram, is extremely uncommon. But I do want to point out that there are a few different cholera vaccines depending on where you practice. There's an oral inactivated vaccine. It comes by a few different names because it's made by different manufacturers, but essentially is all the same vaccine. And there's a Vaxchora vaccine, which has been approved in the US, which is a live oral vaccine. And then there's Dukoral, which is the vaccine that I'm most familiar with because it's available in Australia, which is an oral but inactivated vaccine. Now, as I've said, we rarely use any of these cholera vaccines to protect against cholera, but there is some cross protection that you get from the cholera vaccines for enterotoxigenic E. coli and possibly also some other toxigenic organisms that cause travellers' diarrhoea. So sometimes the cholera vaccine is used off-label to reduce or cause travellers' diarrhoea. Which brings me to the last thing I want to talk about, just in the last couple of minutes, the topic of travellers' diarrhoea. Very briefly, the causes of travellers' diarrhoea are still predominantly bacterial and or viral. Parasites make up the smallest proportion of travellers' diarrhoea, but by contrast make up are relatively quite common in return travellers that we see in places like Australia, where and that's because parasites tend to cause a more persistent illness. So people who are coming to clinics after return from travel, by definition, are more likely to have the more prolonged parasite as an etiology. Our understanding of the etiology of travellers' diarrhoea is changing as we increasingly using multiplex PCR to diagnose diarrhoea as opposed to standard cultures. And we're increasingly realising that you can often find pathogens that may or may not be the cause of someone's symptoms, and that multiple pathogens are often found. So if you're using PCR type technology to diagnose causes of diarrhoea, you really need to look at the context to interpret the likely relevance of any organism that you find. Although I've talked about the different agents that cause traveller's diarrhea as if it's all the same no matter where you go, that's obviously not the case. The actual etiology of traveller's diarrhea varies by region and also varies, has been shown to vary according to people's reason for travel. And that's all to do with different exposures and the relative likelihood of the, acquiring the different pathogens. We say as part of the pre-travel clinic that travellers should only drink bottled or boiled water, should not use water to brush their teeth, and should not drink beverages with ice in it, because they can still be carrying pathogens in untreated water, and that travellers should also be careful with the foods they eat, particularly raw foods, raw salads, meats, fish, etc. Having said that, and whilst that is all very sensible advice, there's lots of studies that actually show that people who try and follow the food rules don't actually get less traveller's diarrhea than those who admit to having broken the food rules. And it's probably because if you eat in a contaminated environment, you're likely to be exposed to pathogens regardless of which food it actually is that you put in your mouth. And really, I mean, we're all very familiar with hand sanitizer now, but washing your hands before you eat and where you eat is probably more important than what you eat. I've already alluded to the fact that the natural history of traveller's diarrhea clearly depends on the actual cause, but most bacterial and viral causes of traveller's diarrhea, which, as I've said, are most common, resolve in 1 to 2 days, even without any treatment. And it tends to be the parasitic causes of traveller's diarrhea that can last longer. So what do we say to our travellers about self-management options? Well, the most important message is to maintain hydration. And apart from maintaining hydration, most travellers can watch and wait without doing anything else and they will recover. However, we do know that some travellers get severe symptoms. Sometimes they have to get on a bus or a train or something else, and they might not be near a toilet. So anti-motility agents for symptomatic relief is a good thing to carry with you in case you do get significant symptoms and it's annoying you. Loperamide, which is Imodium or Gastrostop at the dose shown here, can be used. Antibiotics can be used for more severe cases of traveller's diarrhea as well, either alone or together with anti-motility agents, although we don't recommend anti-motility agents if people have a temperature or blood in the stools. The usual antibiotics that we might suggest to travellers to carry are it's azithromycin, usually 500 milligrams, 3 tablets, take 1 a day for up to 3 days. But there is resistance emerging, and it's because of resistance also that we no longer recommend the quinolones. I won't talk much about rifaximin because it's something that's used more in the US and Europe, and it's not good for most of the invasive bacterial causes of diarrhea, which many of our travellers are likely to get, but I do put it there, partly because a really good reference for how to manage travellers' diarrhea was published by some guidelines in the Journal of Travel Medicine, put together by the International Society of Travel Medicine. And they essentially say if you've got mild diarrhea, you can either do nothing or take just loperamide. If you've got severe diarrhea, you should probably take antibiotics plus or minus loperamide. And if it's moderate, you can use loperamide and you usually don't need antibiotics as well. But when to use antibiotics is a bit controversial because using antibiotics, either diarrhea, getting an acute traveller's diarrhea itself, or and even more so if you take antibiotics for it, increases your chances of 2 things. Firstly, changes in the gut microbiome, which may lead to a post-infectious irritable bowel-like syndrome, and also traveller's diarrhoea and taking antibiotics clearly and definitely increases the chances of picking up a multi-resistant gastrointestinal organism. I realised I'm at time, so I'm just going to flick through the last two slides very, very quickly. These are the areas of the world where you're most likely to acquire a multi-resistant organism, and I've also shown some risk factors for that here, but again, Indian subcontinent being bright red. And then the last slide, I just want to say very quickly, we often get asked about the value of bovine colostrum, which is known as Travelan, and also pre and probiotics in either preventing or treating traveller's diarrhoea. And I can summarise the data to say that there really is no good evidence for pre or probiotics. Travelan does work in reducing enterotoxigenic E. coli, but it is hard to get people to take a tablet before every meal. So that's it.